So good afternoon, everyone, and thank you for joining us this afternoon. My name is Agathe Acchiardo. I'm the founder of ThinkNext, a consultancy specializing in foresight in health. So today we are going to talk about a huge problem, but also a huge opportunity regarding women's health. And this problem, or this opportunity, is related to data, and more specifically, the lack of gender-specific data in medicine. So when it comes to women's health, we usually look at female health-specific issues, like breast cancer, like fertility issues. But this actually only represents 5% of the female health burden. 95% of the female health burden is not really in focus. And I'm speaking about cardiovascular disease, I'm speaking about neurodegenerative disease, autoimmune conditions, respiratory disease that may affect women differently than they affect men. So why is it that we don't focus on this 95%? Well, historically, Western medicine has been based on a fairly simple assumption that apart from the reproductive system, male and female bodies are fairly similar. Therefore, most of the diagnostic tools, most of the drug testing process, most of the treatment guidelines have been designed based on male data. And they don't take enough into account female specificities. So now we've all talked a lot about AI and how it can be applied in healthcare. And if we keep this hypothesis that male and female bodies can be treated the same way with AI, we are going to go straight into a wall. Women's bodies are different, and not just in the reproductive health system. It's not a niche. We're actually talking about 50% of the population, so it is a huge opportunity. And today we are lucky to be aware of this blind spot, and that's why we're here today to discuss how to drive a more gender-specific medicine. So to do so, we are very lucky to have three fantastic experts, and I'm very excited to have them today with us. The first one is Professor Maas. She's an emeritus professor in cardiology, coming from the Radboud University in the Netherlands, and she has dedicated her career to female cardiology. She spent 35 years in clinical practice treating female patients, and she has written a book called A Woman's Heart on Female Cardiology. If you have a chance, I all encourage you to read it. You don't need to be a doctor, and you don't need to be a woman. You'll learn a lot of things about female cardiology.
Also some more books, but this is one of the books.
Yes. We also have the Dr. Lisa Falco with us. She's a data scientist from Switzerland. She holds a PhD in biomedical imaging processing, and she has been working extensively in women's health in the startup world. She is a regular contributor to Forbes on the women's health topics, and she has written the book, Go Figure, The Astonishing Science of the Female Body, which is a fantastic book about the role of female hormones on how they impact cardiovascular health, brain health, and bone health. And finally, we have the Dr. Shaista Hussain. She's a medical doctor from Saudi Arabia. She's a clinical pathologist who turned a machine learning engineer with her company, SAIF. She's focusing on explainable AI, safety, cybersecurity, and compliance for machine learning in healthcare.
Thank you.
So my first question, ladies, to start with, gender-specific medicine is not yet a common topic in medicine, and you are all trailblazers in this emerging field, so I'd like to know how and when did you fall into it?
Well, I became a cardiologist in '88, and I was trained in the '80s that along the male model of a cardiac patient. And we learned that female patients were weird, they had difficult symptoms, and they didn't fit in the model, the male model that was developed in cardiology. And after a couple of years, when I was ready as a cardiologist in my outpatient clinic, there was a female patient, and I remember it was in '91. She got very angry at me, and she said, "You just don't know what I'm having. You're telling all kinds of stories, but you just don't know the reason of my chest pain." And this was really a wake-up call from clinical practice that she forced me to look more into women's cardiology. And I did. And it was also a bit the time when the first publications in the medical journals appeared that there are many differences among men and women during their lifetime in all kinds of fields of cardiovascular disease. So I've learned the most in my whole career from the patients themselves by listening on the floor to what the patients tell you. I think that's where changing starts, to better listen to those we care for.
With me in clinical practice in the lab, I always noticed that the lab parameters, all of you have been to the lab and had your blood tested. And if you were to go to the lab, for example, and right now, and go again after a few hours, and if you've taken a Panadol or something, your blood parameters will change. Similarly, for females, their blood parameters change throughout the month and throughout the week, and it's cyclical. So I always had an issue in the lab with the fact that our reference ranges are fixed, they're static, and they're not dynamic to accommodate changes, which led to a lot of query misdiagnoses or challenges in terms of how to approach a patient. Is it true anemia? Is it pseudo-anemia? And these are not properly classified medical terms. Having gone into machine learning, I still am very hopeful that this will be our pivotal moment to change. But likewise in machine learning, I found that the data sets have inherited a lot of these bad annotation habits from our previous to now, so I'd say our past. And I also found a discrepancy between the male and the female data in terms of how it's annotated or how data is stratified. And that's how I was embarked on this journey.
Yeah, from my side, it was more, I was already in female health, so I was working with data to trying to help women get pregnant faster based on their menstrual cycles and wearables. So I was working very closely to women, helping them through this journey, and I realized how little they knew about their own body, and that the problem was not only the data gap, but actually that all the knowledge that was there was being done in the research never reached the end consumer, or it never reached the women, and so many of their fertility issues could actually be solved if they knew more about their body. And that's why I wrote the book about the female body, to really give women a tool to understand their women and really understanding how fascinating and amazing their bodies are. And it's only actually after the publishing of the book that people are coming to me with all these examples of the gender data gap, how big the discrepancies are, what the lacks are. It was not something I was aware of, because my work up to that point was only due to pure fascination about how amazing it is. But yeah, I've woken up to the issue more and more as we move along.
So I think it would be interesting to share with the audience a few examples of the data gap that you've seen and how you've seen it in your practice and in the different projects you've been involved on. So, Professor Maas, would you like to share some examples?
Yeah. Well, the daily food of the cardiologist is atherosclerosis, the aging of the coronary arteries and the heart. And we have been raised to the concept of stenotic coronary artery disease, stenosis that you can dilate with a coronary intervention, or that you can bypass with surgery. But now it has become clear also with the more novel imaging techniques and testing, functional testing during coronary angiography, that the pathophysiology, the way the blood vessels age, that they show a lot of differences among men and women. Specifically, women between 40 and 70 years of age, they don't have so much stenotic disease, they have more coronary artery spasm. And the spasm can be in the large vessels, in the microvessels, or a combination. And we also know that women have different impact of the traditional risk factors, a higher risk with comparable blood pressure in women compared to men, but also that there are female-specific risk factors related to, for instance, migraine in their teens, hypertensive pregnancies, but also an early natural menopause. So we need to consider our female patients differently. We have to ask different questions, and we need a different way to establish the appropriate diagnosis, to establish the kind of phenotype of the woman we have with chest pain, and then start medication tailored on the individual patient. So in fact, cardiology has become more difficult and complicated, but it's more tailored on the individual patient. And this also accounts for ethnic differences. We know, for instance, in calcium deposits, there are many differences among ethnic groups, and we need to take this into account. And in many guidelines, it's still about patients. But we need to know what kind of patients, what are the characteristics, what is the origin of those patients, what are the ethnic differences. So we need a more tailored patient care.
Thank you.
Yeah, that's true what you say, that the female body is actually a little bit more complicated. And just as you said, Agathe, in the beginning, that it used to be seen as a male body, but with pesky hormones. But the thing is that these hormones, they have a really huge impact on how our body develops all the way from puberty to menopause. It changes how our brain develops, how the structures, the connectivity in the brain is influenced, the cardiovascular system. Every single cell in our body is different. And it's even these cellular differences that are so fascinating, that they have a different environment because of the hormones. That changes how other molecules connect to them, how it influences exactly everything. And up to around now, people have done the same experiments on male and female cells, and most researchers are not even aware if they've been doing the research on female cells or on male cells. And that has a huge impact. And on the preclinical level, there are 5 times more male mice being used in research than female mice. And the reason behind this in the past, it's unofficial, but it seems that it's much easier to get good results and consistent results if you use male mice, because you don't have these complications. But of course, if you use that as an excuse to exclude female mice, you will also not get the same performance on the drug once it's on the market. And out of 80% of all the drugs that had to be retracted from the market was because they did not function equally well, or they had very adverse negative side effects on women compared to men. So what you save in the preclinical research can really punish you in the clinical part. And one other interesting example, I think, where you have this gender disparity, where you should have been doing more research on women compared to men, is Alzheimer's research, where women, or about 2/3 of Alzheimer cases are in women, but only 40% of the clinical research is being conducted on women. So there we have a huge discrepancy.
I'm going to jump on what you said. You brought up two points that I'll pick up on. The first, and I'll do this giving 3 tangible examples of clinical cases, and then the data risks associated with them. The first is in adverse drug reactions and clinical trials. Traditionally, the number of males enrolled in clinical trials far exceeds that of females. Where that poses a risk is that using AI technology, when we start to do predictive or algorithmic predictions to get new people into clinical trials, we're going to inherit that same problem that we did before. Same with adverse drug reaction studies. A second example in medical research that I've done is on PTSD and insomnia, which is also, you find that the number of females that suffer from both of these conditions comorbidly is exponentially higher than males. Yet if you look at publicly available data sets, you'll find an equivalent, and there's an incongruency in terms of the fairness of the representation, so that you've got more women suffering from it, but the data sets show men and women equally. And then a last example is in terms of, if you look at how we're treating the impact of a lack of sleep. So females who have low estrogen heading into menopause or post-menopause, as the estrogen levels drop, their physiology naturally changes as well. And with that physiology change comes a change in how the medicines are received and the receptors respond to it. Yet the medicine remains gender agnostic. Still take a melatonin or take this benzodiazepine, where in fact, based on the available data, that is what people are being taught in the medical schools. That is what's being practiced in the medical career. So this lack of addressing gender biases in data is creating an impact that you and I feel when we go to our GP or we go to our specialist and need a treatment.
So what's interesting in all your answers is that we can see to which extent the gender gap is large. It starts in research and development with male cells and male mice. It continues in clinical trial with the underrepresentation of women. It translates into clinical practice and treatment guidelines. We see that in cardiovascular, in Alzheimer, in insomnia, in a wide range of disease. So that's the picture that we have today. Now, Dr. Shah, you've started to talk about what happens if we bring this legacy in the age of AI. So I'd like to talk a little bit about the future. If we keep going with this gender agnostic approach to medicine, what are the main risks of AI when applied to the health of women?
Well, still, because most data are based on male populations, there will be problems in interpreting many data, and we have the risk that we again that this will lead to misinterpretations in women. But there are some very good examples. For instance, there are now progress is being made in the field of radiology in reading mammograms, that the use of AI improves what the radiologists do. Not that we can skip the radiologist, perhaps cardiologists would like that, but that's a different discussion. So it becomes more reliable if we use AI tools in diagnostic fields. And we also see this coming now in the field of cardiology. But to have a good basis to use AI, we also need female population, ethnic different populations to make it reliable in clinical practice.
If we blindly put in the data that we have today, we're going to just continue that bias, of course. And all bias that is in our data in our society will be continued through those large models. But AI is also really an opportunity to get it right, because you can put in a lot of thought of how you develop the AI systems so that you have an unbiased version at the end. And I rather like to think of AI as an amazing opportunity, because this bias that we have, not necessarily against women, but that we don't know exactly. Doctors that have been practicing for 30 years, it's very hard maybe to teach them new ways of looking at their female patients and change these habits. But if we develop AI systems to guide them, it's actually an opportunity to see their blind spots. So yes, there is a risk, but at least in Europe at the moment, we have a lot of regulation that puts in conditions of how you need to develop this responsibly. So yes, there is a risk, but I really see the future as we have moved beyond that, and the more awareness you get around those things, we will make it better, and I see it more positive.
Yeah, I'm going to second that. I think the perpetuation of the bad habits is something that I'll keep mentioning, and it's an opportunity to pivot away from that. But one of my fears that I tend to alert healthcare practitioners is this ability for us to become dependent on our technology, where we blindly say the AI said. And that can happen as part of human nature when we trust blindly and we say the technology has identified everything. So in the case that data sets have not been annotated or fairly distributed or represented, that blind dependency poses a very severe risk to the health of the future population. On the other hand, we've got the ability of AI and new data sets to look at personalized genomics, personalized medicine, which may be able to help us see into the points that we've overlooked as humans, or those things which we've been unable to handle in terms of our data set or our software capability prior to now. So there's the good and there's the bad of that potential. And what I see as being a transitionary solution for that is our step towards transparency, or transparent or explainable algorithms, which is when you enable the end user, in this case a physician or a clinical healthcare practitioner, to be able to see how an algorithm arrives at its prediction or its output, and then to say, yes, I agree, or no, I don't agree. So keeping this human in the loop is going to be essential. And while we do face the risk of detriment, we also have the opportunity to take in more data and process it for a more personalized medical treatment plan.
So let's take a minute to talk a little bit more about these opportunities that it represents. How can we make responsible AI for women's health? What would be the one or two key actions you would recommend in that space? Dr. Falco, do you want to?
It's coming back to what Dr. Shai, it's all about the data that is being used. So of course, if we don't collect it in clinical trials, we will not get it in. And I think really raising the awareness of the issue, it starts with clinical research. It actually starts with preclinical research with the cells, and then it goes through the whole line. So it's important that that data is there. And also one really important aspect is one of the reasons that a lot of these female-specific issues have not been addressed properly is the fact that women's pain has been ignored pretty much in the past. So a woman would come to the doctor's office and complaining about pain, and that would not be taken seriously because having, for example, painful menstruation is considered being a part of a woman's journey, and very often it's inherited. It has a genetic component. So often the woman's mother would have had the same, and so she would always have heard, this is natural, it's normal that this is painful. And when we start listening to their pain stories and not consider it a normal condition, that will also open doors to other research that then would generate the data that we could use for developing the algorithms.
Dr. Shai, do you want to add on this?
Yeah, I'll just mention the machine learning operations pipeline starts with identifying a problem and then focusing on the data. So you do data processing. This is data cleaning, annotation, and what's going to be key here is having a domain specialist and women leaders, specialists to come in and annotate the data, and then also to have quality assurance at some point in that pipeline, which currently is not a standard part of the machine learning operations pipeline. So having quality assurance and creating an ecosystem where, in general, people want to develop responsibly and develop transparently is going to help. And if you show people the benefits of that and how it enhances their own solution or service offering, I think that helps. And then lastly, to mention that compliance with regulations, there are new regulations, they're very dynamic, they're changing all the time. But by and large, the regulations are there to keep this very largely potential creative technology within an organized system. And I think that these compliance, regulatory compliance is going to help us to make sure that those risks don't get out of hand and can actually guide us towards using this creative technology productively and proactively.
So maybe before we move to Q&A, my last question, and you've started to go in that territory, Dr. Shai, what would be your recommendations for future generations of professionals? Should it be healthcare professional or data scientists?
Well, of course, the mix is the best because we can learn a lot from each other. And if we were to make a change and tailor more on the individual patient, it's important to start with awareness and education. We can only change when education is obliged, sorry, and not a nice thing to have. And it's also not only a thing for female specialists, it's also important to involve as much men as we can have, because it's a joint interest to make the change. But we know that women will put women's health more higher on the agenda. So it's also good to realize that we put women more in leading positions to make those changes and put them on the agenda. So that would be my recommendation for now.
I can only second what you said, and I also think that now when women are taking more and more space in the economy, working more, it has a higher cost to have women not healthy, not working at their full potential. In the UK, there are studies saying that 40% of the women are considering to leave the workforce at menopause, and that will have a huge cost because we need the women there to keep developing our economy. So the society has a huge interest in keeping women healthy, but because that is a pillar of society and economy. On the other hand, also I think that when we are more involved in the work life, we also demand better solutions and we shape the thinking, especially also within tech. To have more women in tech that are part of developing the algorithms, it simply helps the shaping of the thinking in those teams to make sure that you cover those blind spots. And it's not only about women, it's about creating more diversity in general. It will become really important because we're somehow hard coding what we have in our society right now into our algorithms. So that's why these diverse teams in general are so important.
I keep speaking to explainable AI, which is data visuals, to understand how a machine learning program can make its predictions. And it's so important for the end user to be able to understand it. But I'll also mention it's just as important that we learn the technology. So before we let the technology run away from us, I think for data scientists and healthcare professionals, learning Python, learning machine learning, learning how to code and learning how to do fine-tuning or changing parameters within a code where there are mistakes would also help to reduce the blindness and the dependency when a machine makes its output and we just say, oh, the machine is smarter. It may not necessarily be. The machine learning algorithms are designed by us, and therefore they are prone to the same errors that humans already have. So I think my take-home message is the tools are out there. There's free courses. Go out and learn. It's not too late, but go and understand what's happening in coding, what's happening in security, what's happening in explainability, and how you can apply that to your own actual business solution or healthcare solution.
Great, thank you. So now we are going to open the floor for questions. Yes? You were the first one. You were really quick on it.
It's a privilege for the one who's close to you. Thank you very much for this very informative session. My name is Hussain. Actually, it is not a question, but it is, let me say, some sort of enlightenment for hope. We're working on a solution for pregnant women, delivering personalized messages for her health, and utilizing machine learning and AI to create a model to predict an early delivery and any complication that pregnant woman might have. So for this, I'm really welcoming any feedback from all of you. Later session, if you have anything we can add to take in consideration, we will be happy for that. Our aim is to have a healthier pregnancy and safer delivery for a better and healthier future. Thank you.
But I presume you work closely with the gynecologist.
Yes.
Yeah, that's important.
Yes, of course.
Yeah.
Yes, of course.
I would add that you would probably want to consider using sensors and IoT, Internet of Things, to pick up different biomarkers within the female as part of the predictive process and incorporate that into the machine learning process. And then the second thing is, because you're dealing with a sensitive population, pregnant women at that, to definitely make sure that before this model is deployed to the public, that you've applied several layers of responsible AI and transparent AI to make sure that the power rests with the end user. So safety and sensors.
Yeah, on phase one, we are using different patent without any sensors attributes, just collecting some attributes that might affect the pregnancy or delivery, early delivery, without hardware, only software, like PMI, medical history, all those things. We are just looking into these things.
I actually have a concrete example because I was working with wearables and we were tracking pregnant women. And we saw that about 5 weeks before delivery, heart rate drops, starts going down. And we didn't really understand why that happened. But what I learned later when I wrote my book is that progesterone keeps increasing the whole pregnancy, but in order to induce the contractions, it needs to drop. And therefore, you actually have this drop in heart rates just before, because progesterone is driving heart rate. So I think my advice would be really to understand the physiology behind it, because I'm a data scientist. It's quite funny, Dr. Shaye, she's a doctor, she talks about the algorithms, and I'm the data scientist, I keep talking about the medical part, because I realized in my work I cannot build a good algorithms if I don't understand the science, what is driving those, and really trying to understand, figure out this amazing puzzle that is the human body, to see what are the drivers. And I think you need to have this holistic view on it. And data scientists, they tend to just take all the data and shove it in and see what comes out. It doesn't work in the end. If you want something really solid, okay, now it does work to some extent with the large language models. So it's kind of basculated the landscape from something we actually needed to understand. And now when you scrape the whole internet and put it into one algorithm, somehow you get away with not understanding what is happening. But up to until 2 years ago, you actually needed to understand those factors. So now I don't know what to do.
Good. Any other question? Yeah? For you?
First of all, thank you so much for the super informative session. This was not what I was expecting when I sat down, and I was so positively surprised. Thank you for touching upon women's issues. I mean, the inner feminist in me is just jumping for joy. The World Economic Forum has estimated that it will take about 134 years to reach gender pay equality. Is there a data equality in sight? If yes, how far? Will it take another 100 years, or will the development be exponential, like in all things technology? And what can we do? I mean, Dr. Maas, you touched upon this. What can we do to facilitate that we reach that equality in data? Do we have to encourage women to participate in more clinical trials, or is there something that we can do?
Well, I think you're doing it now because you ask the difficult questions.
Exactly.
And that's the way to change. Keep asking those questions to all kind of fora. But there's been a very nice series of papers in the New England Journal of Medicine this year. And I remember at the end of July, there was an interesting paper about the LGBTQ community, that it will take about 750 years before the health data we have of these people, and we know there's gender fluid people, that it will take so long before our knowledge is, you know, in the right place. So we need to put these issues on the agenda where it belongs.
I'm much more optimistic. It's true that in terms of years, we're far behind. I mean, we're 100 years behind in terms of clinical research, but if you look at the data quantities that we collect today compared to in the past, I think it will go really quickly to get up on those, to equalize those numbers. And also there's a lot of really interesting things happen in the femtech industry, and a lot of femtech companies and menstrual trackers like Clue and Flow that are collecting data about the female body, and they're working together with universities, sharing all this daily data around healthy women as well. And I think we have to start to understand, how does a healthy woman work? What's her specifics? What's normal, what's not normal? And we didn't know that before. And I think this industry is a great opportunity. And they also, what's really important, they put a lot of effort in data privacy, because this is very private data. And of course, there's been a lot of setback in the US due to Roe versus Wade, that women were scared of sharing their data because it could be used against them. But the positive effect on the tech side is that the privacy concerns have been taken much more seriously. And also something that I work pretty closely with many of those companies, and they say women really wants to share their data. When they know it's about research, they're very happy to click that button and say, I share my data with this and that research project. So there's a very positive movement in this space. It will take time, but we're on a good way.
First, I'm going to thank you for your question. It's super relevant, and thanks for being here. To answer your question, I think your second question almost answered the first question. So how do we get there? It's by saying, how do we get there? It's by saying, how do we help? And like what we're doing at SAFEcheck is we're applying metrics to make sure that algorithms that are out there, we screen from the data set level. So as to make sure that as public end users of AI systems, you interrogate and say, before I use this AI system, I want to know that the data has been trained fairly and is unbiased. That's number one. Number two, in terms of the optimism, which I share with Dr. Falco here, technology is growing exponentially, which means our steps towards making progress are happening faster. Don't know how long it'll take, but I definitely am hopeful that if we start to apply these metrics, the growth trajectory will be much more expedited. And we have this chance now in the present moment to make sure that the data that we take forward doesn't have those mistakes of the past. If we do that, I believe that we can exponentially grow in a trajectory that we've never seen before. So hopefully we beat 100 years.
Just to complement, I love the question, how we can help, and I think that's a call to action for everyone in the audience. It's really about spreading the knowledge and the awareness around the gender data gap in medicine. It's about challenging your doctor, like the Professor Maas 30 years ago, to prompt them to think differently. It's about discussing with your colleagues. I'm assuming some of you work in the health sector, and questioning to which extent the guidelines reflect gender specificities, to which extent the R&D process took into account female specificities. I have worked in health, I have a background in pharma, and I have lots of friends still in pharma, and recently I was discussing with a friend who is launching a very expensive clinical trial, and we were just on a Sunday brunch, and I still told her, do you have a KPI on the number of female investigators you're going to have on your trial? Because of course, if you have more female investigators, you're more likely to have more females in your trial. You're more likely to be curious about understanding the data coming out of the trial. So it's really a call to action for everyone to spread the message at brunch, with your friends, with your colleagues, with your doctors, in your working environment, to raise the awareness about the gender data gap. Maybe we have time for one last question?
So for me, what I'm interested in is how long before these data sets go from research to practice for the everyday woman to be able to go to her GP and be like, okay, I took an elective blood test, I've got all these interesting biomarkers, can you interpret it for me? That's my first question. And the second question is, how do we, beyond gender diversity, how do we ensure ethnic diversity and socioeconomic diversity in the data sets that we collect?
I'm going to jump on this one. I love it. And you prompted me to mention something I should have mentioned earlier, which is the publicly available data sets that we have now, they're already doing what you're saying. The people who are developing these new algorithms are going on the web and accruing all of these public data sets. This is what we're talking about, is are those public data sets fair? Fair meaning, do they fairly represent the populations to which we're going to be using those predictions on? That means socioeconomically, race and ethnicity, or any other demographic profile that you can imagine. And where the discrepancy currently lies is in the gender or in the race, and this is where I go back to data processing prior to applying a machine learning algorithm. It's to make sure that you have domain specialists to say, yes, this is representative. If you're going to be predicting glaucoma in a subpopulation in sub-Saharan Africa, your training data should also be from a similar representative population. And the data should be stratified just as well to represent the age groups of those people equally. What is happening with that is a current issue is publicly available data sets don't have this information, and this is where the distrust begins. So it's already doing, to answer your first question, that's already happening, but is it happening appropriately and representatively? This is where the concept of responsible AI comes in.
I think I just want to, of course, second what you said. It's a great question, and especially about the socioeconomic status, because in women's health, they actually shown that socioeconomic status has a higher impact on your health than it does ethnicity. So the differences are much larger from rich to poor than it is if you're Asian, African, European. But how to really counter that aspect, it has not been seen so much in general. When we developed our algorithms for fertility, we never considered socioeconomic status in that. And it's a huge gap, so thank you for raising it. I don't have anything to add to what Dr. Shai said, but thank you for your question.
Perhaps I can add. In the outpatient clinic, the socio-economic problems will be put aside because the doctor is not going to solve that. And we also have to realize that change the ongoing knowledge, the implementation of knowledge, also when you talk about gender and diversity, lands difficult in clinical practice because most doctors haven't learned about it. They don't feel comfortable with changing concepts, and so they keep doing what they always did till the next generation comes in. So that's a huge problem. It's an implementation problem of knowledge.
At the same time, AI in that case could be an opportunity to drive the change at scale and possibly faster than in a human manner. Well, thank you very much all for joining the session today. Thank you to our three experts for sharing their insights and their expertise. And I would encourage everyone in the audience to spread the knowledge, the awareness, challenge these assumptions about gender agnostic medicine. It's up to all of you to drive the change and to carry this message. So thank you very much for being with us today.